Great. So just making sure you can hear me okay.
Yeah, everything's good. Coming
Perfect.
through loud and clear.
Okay, great. Hi, everyone. Thanks for joining today. So as mentioned, my name is Candace Nessick, and today we're going to talk about ketamine and ketamine-assisted therapy and try to ask the question, is this a true game changer in mental health treatment, or is it more of a temporary bridge while other psychedelic therapies emerge? My goal today is to give you some practical clarity, what ketamine actually does, what the evidence really shows, and how it's regulated in Canada, and more specifically Ontario, and where pharmacists fit in. I'd like to begin by acknowledging that the land where I live and work is the unceded territory of the Cowichan tribes. I recognize Indigenous peoples as the original stewards of this land and acknowledge the ongoing importance of Indigenous perspectives in health, healing, and wellness, especially when it comes to psychedelic medicines that we're going to be talking about. Just briefly for transparency, I was previously employed by Numinous Wellness, which operates a few psychedelic treatment clinics in Canada and the USA and conducts psychedelic related research. I've also received an honorarium from the Ontario Pharmacists Association for delivering today's session. As mentioned as well, this webinar is supported through funding from Ontario Health's Mental Health and Addiction Centre of Excellence. Okay, so by the end of this presentation, I want you to feel comfortable with four main things. First, understanding how ketamine works pharmacologically and the various ways it can be administered. Second, how ketamine compares to other psychedelics that you're increasingly hearing about. Third, how ketamine is actually regulated in Canada. And finally, the practical question, what is our role as pharmacists when these prescriptions show up? So let's get into it. What are psychedelics? When we talk about psychedelics, we're really referring to substances that alter perception, mood, and cognition. Psychedelics are often discussed as one category, but clinically they fall into very different drug classes with unique pharmacological properties. We have classical psychedelics like psilocybin, LSD, DMT, and mescaline, entactogens like MDMA, atypical hallucinogens like ibogaine, and dissociative anesthetics, which is where ketamine sits. Ketamine is not often thought of as a psychedelic, but does fall under the umbrella term given its dissociative and perceptive changes. The excitement around psychedelics really comes from a shift in how we think about treating mental illness. Traditionally, psychiatry is focused on monoamines such as serotonin, dopamine, and norepinephrine that leads to gradual symptom improvement. Psychedelic therapies instead appear to promote neuroplasticity, meaning the brain may temporarily become more adaptable to change and is able to grow new neural connections. So this image shows neural connections in the brain before on the left and after on the right, psilocybin, after psilocybin's administered. So just seeing the vast increase in neural connections. The other major difference is speed. Some patients improve within hours to days rather than weeks. Psychedelics are increasingly being studied for more treatment-resistant conditions that otherwise were unresponsive to traditionally available treatments, such as complex and resistance PTSD and treatment-resistant depression. So overall, this new group of medications is stirring up quite a lot of excitement and potential in the field of psychiatry. Another key concept is that many psychedelic treatments are not intended to work as medications alone. Instead, the drug is used to enhance therapy in a controlled setting with trained therapists, so-called psychedelic-assisted therapy. This often includes pre-dosing preparation sessions as well as post-dose integration sessions in the day or two following a dose when the brain is most neuroplastic. So the intervention becomes drug plus therapeutic environment rather than pharmacotherapy alone, which creates some unique evidence and regulatory challenges. So I see the poll showed up here. So let's do a quick poll to get everyone thinking. Which psychedelic do you think currently has the strongest clinical evidence in psychiatry? Okay, so seeing that there's definitely a bit of a mix, which is great because I think there's a lot of evidence out there right now that we're trying to make sense of. I would agree that the correct answer is ketamine. At the very least, ketamine has the most evidence, and we're going to discuss why coming up here. But there's some good evidence for the other two as well. So I'm going to touch on those. And I'm glad that some of you aren't sure. So hopefully you can learn a little bit over the next few slides. Okay, great. So let's talk about MDMA first, just to give you a lay of the land. So MDMA-assisted therapy has actually produced some of the strongest psychiatric trial results we've seen in decades for PTSD. In phase 3 trials, over 70% of participants no longer met diagnostic criteria for PTSD after treatment with which included two doses of MDMA delivered as MDMA-assisted therapy. So it was MDMA with the psychotherapy. These phase 3 trials led to the submission of a new drug application to the FDA in 2024. However, the FDA identified several concerns in the study design, such as issues around blinding with a medication that's very difficult to blind patients and providers to, and unanswered safety questions. So that ultimately led to the rejection of the new drug application in 2024, which continues to be a bit of a heated debate in the psychedelic world. And this really slowed momentum across the entire field. Psilocybin is the next in line for FDA approval. It's shown really strong antidepressant effects in clinical trials so far, including a phase 2B as well as a phase 3 trial, which delivered psilocybin as psilocybin-assisted therapy for treatment-resistant depression. So just as maybe a quick interlude, to be able to apply for a new drug application to the FDA or Health Canada, you typically need two strong strong study design, phase 3 trials to be able to present that data for approval. So everybody right now is working towards those two phase 3 trials to demonstrate efficacy. What stands out particularly for psilocybin is the magnitude of response after a single dose of 25 milligrams administered alongside therapy. It's important to note that a second phase 3 trial is currently in progress by Compass Pathways, and they're adding a second 25 milligram psilocybin dose after 3 weeks. So it'll be interesting to see if any further improvements are seen with 2 doses of psilocybin instead of just 1. At this point, I think it's helpful to clarify how psychedelics are scheduled in Canada because this often causes some confusion. So, under the Controlled Drugs and Substances Act, drugs are scheduled based on risk of misuse and harm. All psychedelic drugs are currently scheduled under the CDSA. Drugs like psilocybin and the other classical psychedelics are Schedule 3 substances, meaning they have a potential for misuse and harm, but the risk is lower than, say, Schedule 1 and 2. MDMA is a Schedule 1 substance, deeming it kind of the highest risk for misuse and harm, as is ketamine. But being scheduled under the CDSA does not make these drugs illegal to prescribe, but all drugs in Canada do need an approved indication by Health Canada in order to be accessible for prescribing. So in the case of psychedelics, only ketamine has an approved indication, which began a long time ago as an indication for anesthesia. Routine prescribing of all the others isn't permitted outside of clinical trials or the Special Access Program, which is where some patients are accessing drugs like psilocybin and MDMA. So given this, ketamine is currently the most accessible psychedelic drug for medical use. We're seeing this across Canada as well. So thousands of patients are already receiving ketamine treatment annually across more than 50 clinics in Canada. In contrast, only a few hundred patients total have accessed psilocybin or MDMA legally through the Special Access Program. They are, of course, accessed and used either recreationally or from underground sources quite prevalently. So while media attention often focuses on emerging psychedelics such as psilocybin and MDMA, ketamine is really the substance driving real-world implementation right now, and hence why we tend to have the most research on it to date. So with that context, we're going to shift our focus specifically to ketamine, quickly go over how it works, how it's used clinically, and what pharmacists should understand when encountering this in practice. So ketamine works very differently from traditional antidepressants, and certainly differently than other psychedelics. Rather than directly targeting monoamines like serotonin, it blocks NMDA or an N-methyl D-aspartate receptors. This triggers a glutamate surge and downstream AMPA activation. This ultimately increases brain-derived neurotropic factor signaling and promotes rapid synapses or synapse formation. So clinically, this is thought to explain why patients can experience really rapid antidepressant effects within hours instead of weeks from ketamine. But how does ketamine compare to other leading psychedelics such as psilocybin and MDMA? So as mentioned, ketamine is an NMDA receptor antagonist that increases glutamate signaling and downstream neuroplasticity, producing a dissociative state that lasts roughly 40 to 90 minutes. Psilocybin, in contrast, primarily acts as a serotonin 5-HT2A receptor agonist, as does all the classical psychedelics, which leads to an altered perception, cognitive flexibility, and what are often described as mystical or insight-oriented experiences lasting about 4 to 6 hours, so quite a bit longer. Some people also describe ego dissolution, meaning the normal sense of self feels temporarily less defined. MDMA works differently again, increasing serotonin, dopamine, and norepinephrine release, so all those monoamines, but also enhances oxytocin and reduces amygdala fear response, which is why it appears particularly helpful for trauma processing. Its duration of action is also around 3 to 6 hours. So ketamine's shorter duration of action really makes it more operationally feasible in medical settings compared to other psychedelics that require longer monitored sessions. That also makes it easier to research in that sense because it's not quite as expensive because we don't need, the monitored sessions can be quite lengthy and expensive in the world of research. So ketamine can be administered in a number of different dosage forms, including intravenous, intramuscular, intranasal, and oral or sublingual. Bioavailability is, of course, 100% with intravenous ketamine and reduces across forms down to oral, which is only about 17 to 25% available. Sublingual ketamine is slightly more bioavailable than oral, usually somewhere around 25 to 50%. In general, though, the bioavailability of oral and sublingual ketamine is quite variable, leading to higher doses required to achieve the same effect. IV, of course, has the advantage that it can be titrated at any point based on patient response, since it's given as an infusion, whereas something like intramuscular is administered all at once and can't be changed after it's injected. S-ketamine, which is the S enantiomer of ketamine, only comes in intranasal form, and you maybe are seeing this in practice. But racemic ketamine can also be used intranasally and is quite a bit less expensive than S-ketamine, so you might also be seeing this prescribed. Compounded oral and sublingual ketamine are also less expensive options, but because higher doses are needed, adverse effects can increase. In psychiatric use, ketamine is administered at doses lower than what is used for anesthesia. So this slide just summarizes the common dosing regimens of the dosage forms we just discussed on the previous slide. The main takeaway is that dosing varies depending on bioavailability, and really just to recognize that ketamine dosing is generally delivered over a few weeks versus, say, daily antidepressant treatment. So for example, a common IV dosing regimen is 0.5 milligrams per kilogram of body weight, infused over 40 minutes for a total of 6 infusions over 2 to 3 weeks. Okay, so let's move on to what indications ketamine has evidence for. Ketamine hydrochloride is only approved for anesthesia in Canada. Any other use of ketamine in Canada is considered off-label, but that's what makes it accessible on the market because it does have that approved indication that's been around forever, and now it's being used for other uses other than anesthesia. S-ketamine is approved in Canada as a nasal spray for treatment-resistant depression in adults based on successful phase 3 clinical trials. So just like what was done for MDMA and is in progress for psilocybin, those were considered successful enough for Health Canada to approve it. and it demonstrated efficacy in both the treatment of treatment-resistant depression and the prevention of relapse. In particular, what is impressive is ketamine's ability to demonstrate, as mentioned, that rapid antidepressant effect within 24 hours. These trials, though, evaluated ketamine without psychotherapy. S-ketamine is only approved for use under very strict conditions. So it has to be used with a newly initiated oral antidepressant, has to be administered in a certified clinic, and patients must be monitored for at least 2 hours post-dose. So patients must be enrolled in the Janssen Journey program to access this medication. To dispense S-ketamine, a pharmacy must also be enrolled in the Janssen Journey program, and they would dispense it to the clinic staff who will oversee administration for a given patient. So this isn't for at-home use. Both S-ketamine and ketamine have evidence for treatment-resistant depression and have also been studied in comparator trials to other standard treatments for treatment-resistant depression. So in the ESCAPE TRD trial, S-ketamine outperformed quetiapine XR in remission and relapse prevention in treatment-resistant depression. And likewise, in the ELECT-D trial, IV ketamine was found to be non-inferior or as good as, or even a bit better, to electroconvulsive therapy for non-psychotic treatment-resistant depression, but with fewer cognitive adverse effects, which is really beneficial. For pharmacists, I think this reinforces that ketamine and S-ketamine have been directly compared to established psychiatric treatments, and so far they hold up. Okay, so let's move on to an important question. Does adding structural therapy to ketamine improve outcomes? So I think the theory is, of course, compelling, as ketamine may temporarily enhance that neuroplasticity, creating a window where therapy could be more effective. Let's look at some examples that study this. So looking at the substance use disorder literature first, there are a few randomized controlled trials worth noting, including 2 focused on alcohol use disorder and 1 on cocaine use disorder. In these studies, ketamine infusions were paired with structured psychotherapies such as motivational enhancement therapy. Control groups typically received an active placebo like midazolam, combined with the same psychotherapy or ketamine paired with a lower intensity therapy comparator, such as just like alcohol education program, for example. Across these trials, I'd say the signal is pretty consistent. Ketamine alone doesn't appear to meaningfully reduce relapse risk for these substance use disorders, but when combined with structured behavior therapy, abstinence outcomes improve. Another study looked at depression, anxiety, and PTSD populations, and this was Dorr and colleagues in the study reported large symptom reductions in patients receiving ketamine combined with in-session therapy. However, this was an uncontrolled real-world data set without a placebo group. In contrast, a large retrospective analysis comparing ketamine alone versus ketamine plus psychotherapy in depression and PTSD tells a bit of a different story. So in this study, both groups improved substantially, but there was no statistically significant difference between ketamine alone and ketamine plus psychotherapy. It's important to note that this wasn't a randomized placebo-controlled trial either, and there are limitations that I noticed. First, the researchers relaxed the inclusion criteria, whereas those participants in the ketamine-only group could actually have had up to 40% of their visits at the clinic be psychotherapy alone, meaning they were likely still receiving some level of psychotherapy. Secondly, various forms of psychotherapy were permitted and used since this was a retrospective study, so that was really difficult to be able to control for what level of therapy patients were getting. And then what still remains unclear to me is the timing of the psychotherapy visits in relation to the ketamine dosing. So this is really important because that window of enhanced neuroplasticity post-ketamine is likely the optimal time for therapy, and it wasn't clear if that was delivered or if it was just in supportive care during the session itself. So despite this, the study does contribute overall to the evidence base on whether ketamine-assisted therapy is more effective than ketamine alone. And at this point, I'd say that more research is, of course, warranted. But in practice, we are seeing many clinicians and providers, or clinics and providers, advocating for the use of ketamine-assisted therapy as a treatment model. Okay, so up to this point, we've reviewed the pharmacology, the evidence base, emerging therapy models for ketamine, such as ketamine-assisted therapy. So let's return to the central question. Is ketamine-assisted therapy truly transformative, or is it serving as a bridge while other psychedelic treatments continue to work towards approval? So as you can see, ketamine already has established evidence for depression, including head-to-head comparisons with standard care like quetiapine and even ECT. Further research has shown that ketamine alongside structured therapy may have additional benefits, especially in substance use disorders. But no research has currently compared ketamine to other psychedelics like psilocybin and MDMA. But let's quickly summarize what we do know. Ketamine definitely exerts its effect quickly, which is a plus, but often requires repeated dosing to maintain benefit, more than the other psychedelics at least. MDMA and psilocybin have primarily been studied only in the context of psychedelic-assisted therapy for psychiatric conditions, so that's a little bit different as well. MDMA currently has the strongest data for PTSD, particularly trauma processing, and typically involves only a few dosing sessions, usually 3. Psilocybin appears to produce larger effect size in depression than we have seen with ketamine, potentially by disrupting rigid thought patterns through the 5-HT2A activation. And it also requires less doses than ketamine, usually 1 or 2. So, ketamine may not be the winner, but it is currently the most accessible. That's why many view it as the first wave of psychedelic medicine, or possibly a placeholder for what comes next. I think if the other psychedelics are approved for medical use, we're going to see off-label use across all of them, and each one will eventually become a leader in their own indications. There's also other psychedelics being studied as well, such as LSD and DMT, but they're further behind, so those are yet to be determined. Perhaps ketamine will fall behind the others, but its shorter duration of action will likely remain an advantage in clinical settings. Likewise, ketamine has an established treatment model as pharmacotherapy alone, which also provides further advantages and options to patients. Okay, so at this point, we're going to shift from evidence to regulation because in practice, regulatory structure determines how and where these therapies are delivered. So we already touched a bit on federal regulations, but just to refresh you, ketamine is a Schedule 1 substance governed federally under the Controlled Drugs and Substances Act. Ketamine hydrochloride is approved only for anesthesia. S-ketamine nasal spray is approved for treatment-resistant depression under strict conditions. So any psychiatric use of ketamine for other indications or in any other dosage form is all done so off-label. Provincially in Ontario, administration is governed by the College of Physicians and Surgeons of Ontario. So IV and IM ketamine must be administered in college-approved out-of-hospital premises, which require specific safety infrastructure, crash carts, oxygen, recovery standards, and appropriate physician oversight. An MD or RN must be present, and deeper sedation requires a specially qualified physician. Other routes of ketamine administered outside hospital settings falls under the complementary and alternative medicine policy, which provides more flexibility but still requires professional accountability. So in Ontario, the route of administration significantly changes the regulatory expectations. How does this compare to other provinces? Well, Alberta has probably set out the most explicit standards for psychedelic-assisted therapy to date, and is really the only province that has actually decided to govern psychedelic-assisted therapy versus just the psychedelic itself. Whereas most provinces, ketamine's regulated still under current anesthesia and practice policies. We're going to likely see this continue to evolve, perhaps even in Ontario as well. Okay, so let's jump into another quick poll. Perfect. So if you received a prescription today for oral ketamine for depression, what would be your biggest concern? Okay. Yeah, so regulatory issues for sure. Yeah, it looks like a bit of a spread across all of them, with some of you saying you wouldn't feel comfortable dispensing it. So, yeah, that's totally fair with kind of where the evidence at, and I think just how quickly things are evolving in the world of psychedelics and ketamine. I'm hoping that we're going to cover some of this in the next few slides, which I hope will increase your comfort level a bit. But I think these are all legitimate concerns that, as things continue to evolve and grow, will hopefully provide be able to provide more information, education, and framework for pharmacists. Sorry. Okay. So let's move on here. Let's get into some tips for pharmacy practice. In community practice, pharmacists may be involved in dispensing S-ketamine to clinics through the Janssen Journey program or IV or compounded ketamine to patients, depending on where it's being administered. And as we do for any medication, it's important to verify the indication, the dose, the route of administration of ketamine when you're dispensing a prescription for it, especially because most of ketamine is being done so off-label. So you're going to have to look into monographs and studies if you're not familiar with how it's being prescribed and gather more information from the patient or the prescriber if needed. You may need to look into the primary literature as well, since the research is evolving so quickly. So I'll teach you about certain dosage forms, and then things could change in another few months, or things could be used at a different dose based on new evidence that has emerged. For IV and IM ketamine prescribed for psychiatric indications, pharmacists should, if possible, ensure prescriptions are issued by authorized prescribers and administered in appropriately accredited clinical settings, consistent with CPSO standards. And I believe that the CPSO does post inspection outcomes on its website as well. But hopefully you might have some familiarity with the clinics around you and be able to maybe have a good relationship with the prescribers or the health professionals working there to be able to ask questions. And then pharmacists are, of course, likely to receive questions from patients about ketamine as an option and should have enough information to provide evidence-based answers as well. Pharmacists may be involved in confirming safety of ketamine use by determining its safety against other medications patients are taking. Drug interaction screening is always a skill that pharmacists are best equipped to lead. And ketamine does have a few drug interactions that you should be aware of. So CNS depressants, including alcohol, can cause additive sedation with ketamine. Lamotrigine may reduce the subjective or therapeutic experience of ketamine, while benzodiazepines may actually blunt ketamine's antidepressant response and shorten its duration of action. Ketamine undergoes extensive first pass hepatic elimination, of course, when taken orally. And a major contributor for this is CYP3A4. So CYP3A4 inhibitors and inducers can either increase and decrease oral ketamine exposure, and CYP2B6 inhibitors can increase S-ketamine specific levels. And finally, because ketamine can transiently increase blood pressure and heart rate, and this is actually consistent so far across all the psychedelics, cardiovascular medications and baseline risk factors should be reviewed carefully. But typically, the peak effect that it's going to have is kind of when the peak dose is happening, and then it'll slowly dissipate. So it's usually a short period of time that this occurs, but it's definitely worth reviewing and cautioning. And then safety counseling, of course, is an important part of pharmacists, an important role of pharmacists if you're ever dispensing ketamine for patient use or monitoring a patient taking ketamine. So patients shouldn't drive or operate machinery for at least 24 hours after dosing, given the neuropsychiatric and dissociative effects of the drug. So in clinics, for example, if a patient is, going to a clinic to get dosed, it's typically required that they have a ride home at the end, and they shouldn't be driving home themselves. And it's also recommended that at-home dosing should not be done alone. So they should have somebody there with them as a support that can keep an eye on how they're doing medically. Chronic or high frequency use, so we talked about that long-term use as being a potential risk. One thing that we do see potential being a risk is increasing the risk of ketamine-induced uropathy. So this is a chronic inflammatory injury to the bladder and the lower urinary tract, which is associated primarily with repeated or high frequency ketamine use. So it's most commonly seen in recreational users or patients using high doses over prolonged periods. Um, Generally, it's a lower risk when you use kind of with the standard ketamine dosing protocol that we're seeing right now in clinics. So, but asking about urinary symptoms at follow-up visits would be important, and also educating patients about that. There's also, of course, misuse potential of ketamine as a recreational drug. So, of course, as pharmacists, we should also be always be monitoring for early refill requests, multiple prescribers. Um, but when used appropriately in clinical settings, especially when combined with that ketamine-assisted therapy, this risk is generally quite low as it's used very much to enhance that therapeutic process, but always something to be aware of and to have caution for. And then, of course, mood and cognitive function should be reassessed regularly to determine whether therapy remains appropriate. Because, again, prolonged or high frequency use can be associated with cognitive impairment, but this is generally beyond what the typical protocol would cause. And then, of course, I don't have this on the slide, but it is important to note that ketamine is contraindicated in pregnancy. So that should also be a awareness for you. And currently, it's only approved for use in adults. However, I believe that there have been some studies done in adolescent pediatric groups around those with depression with like active suicidality or suicide risks. So more, again, more research and evidence to be coming. Okay, so that brings us to the end of the presentation. So, in summary, ketamine offers a novel glutamate-mediated mechanism with rapid antidepressant effects and a growing evidence base. Ketamine-assisted therapy shows promise, particularly in substance use disorders, but evidence still varies by condition. And most psychiatric ketamine use in Canada is off-label and regulated both federally and provincially. Pharmacists play a critical role, so in verification, interaction screening, patient education, and ongoing monitoring. You may be getting questions from clinics or patients. I think some clinics are, running it themselves without maybe engaging in pharmacists, but I think that pharmacists, especially for patients that they have a more of a longer term relationship with at a pharmacy, would be a real benefit to their team. And whether ketamine proves to be a long-term game changer or just a placeholder, it's already part of contemporary mental health practice, and we are part of that care team. So it's important that we are aware and are able to help to contribute to the care of those patients. Okay, thank you. The rest of my slides are references. You're welcome. I've posted lots of references. So you want to dive deeper into the evidence and the studies and some of those resources, they're there for you as well.
Awesome. Well, thank you, Candice. One of the questions was, will the slides be available to share this evening? So I think the answer to that is yes.
Yeah, I've sent them. I've sent them, so I'm really happy for them to be shared. So,
Perfect.
absolutely.
If anyone wants to reach out to me at education@opatoday.com, be happy to share a set of the slides with you in a PDF version. Also, right now, I'd like to ask if anyone in our audience does have any questions at all for
Mhm.
Candice. I do actually have a question. I was just wondering, what does the therapy actually look like? Like, I assume it's in like a cozy, comfy, clinical type setting. But how long does it go on for? Does the behavioral therapy happen during the actual like dosing session, or does it take place afterwards during the elasticity period? Or could you
Yeah,
describe that a little bit?
totally. Yeah, really great question. And I'm seeing some questions in the chat too, so I'm helping to get to that too. Um, and I was going to say I provided my email address too. So if any questions, if you're seeing things in practice, or you have questions, feel free to email me. If I don't know the answer, I have lots of colleagues in the area that I could also try to, get some information from. So want to offer that. The therapy, so yeah, so what the therapy looks like. So psychedelic assisted therapy is generally what it looks like is it's usually structured. It's there's a lot of training for therapists to actually like therapists generally are supposed to get additional training in psychedelic assisted therapy itself to really understand that that state that that patients get into and to how to work with that and to understand the vulnerability of it as well. Usually there's some preparatory sessions going in. This is what it's going to feel like. Often for psychedelics, for somebody to get into like a dissociative or psychedelic state can be maybe a little bit scary or unfamiliar or unknown. So there's a lot of preparation for like what to do if you feel nervous or scared, to just sort of don't close yourself off. Just kind of go with the flow and like you're safe, you're okay, we're there with you. You just need to, be open to whatever kind of comes up or happens. And then to set your intentions too for what you want to get out of the treatment, right? So, what are your intentions? Because that often can help. So, in the world of psychedelic assisted therapy, they talk about the set and setting. So, making sure that the setting you're in is very safe and comfortable and conducive to the neuroplasticity that's going to happen in that dissociative state. And then it's also the set. So, what you're coming into, your mindset coming into it as well, and what you're expecting and hoping to get from it. And then during the session, I'd say that vastly for most psychedelics, patients are in their own world. So they are usually they have like a sleep mask on. It's usually recommended to kind of have your eyes closed. Typically, you're laying down on like a couch, or a chair that can kind of lean back. You have a blanket. You're really comfy and cozy, right? So meant to feel really safe. And then often you'll also have music, so headphones on, and they recommend like classical music, not things not with words. And that kind of helps to really kind of take you a little bit on that journey, so to speak. Um, and but I will say the one exception to that is MDMA. So MDMA is because it's mixed with with a stimulant, it's a little bit more of an active treatment in which the amygdala response comes down, the fear response comes down, and patients actually can engage in therapy and conversation with the therapist well under the drug. They're less like in their own world. So there's some active therapy happening usually during MDMA assisted therapy, which provides a really great opportunity to be able to talk about things, maybe past trauma that you otherwise wouldn't be able to because you'd be too scared. You're able to do that, which allows you to start to process it. And then following psychedelic therapy, usually like within 24 hours of your dosing, there's usually an integration session, which allows you to come and talk to the therapist and to really build on like what did you experience, what came up, what does that mean for you, etc. And there might be a few integration sessions after. So that's usually what the psychedelic assisted therapy looks like. And it should be structured and it should be by therapists who have training. So if you're looking at clinics and you're not sure, like if a patient's, thinking about a good clinic or not, some are doing group therapy for ketamine, which is okay. I would always look for like how many health professionals are in the room with everybody. Is it a good balance? Are there enough people to respond? Like if everybody was having like acute, things going on, would there be enough health professionals to be able to help them? Yeah, you want to make sure that that's very well done and make sure that the safety of the patient's at the forefront.
Yeah, so there's no real like say with like microdosing psilocybin, there's not really so much of a do-it-yourself perspective for ketamine-assisted therapy because of the behavioral component.
Exactly. That it's really meant to be like a structured program with trained health professionals. Yeah. Doesn't mean
Um,
people won't try to do things on their
ab-
own, but
Absolutely, I do think pharmacists will be receiving questions from that
yeah.
do-it-yourself cohort as well, which is important.
It's
Uh,
expensive and can be inaccessible for people, but I don't ever recommend that someone undergoes like a therapeutic dose of psychedelics without, at the very least, having a therapist on board because things can come up that you don't even realize could come up, and you need to be able to have the help to work through that. Yeah.
For sure. We do have a number of questions coming
Okay.
in. I'm not sure where you can see the questions. I'm not sure where you want to start.
Okay. Should I look in the chat or the
Yeah,
Q&A?
there's some in both. Like in the chat, there's about 6 or 7 questions, and then in the Q&A we have a couple of unanswered.
Okay. Okay, so I'm seeing one question. What's monitored after the dose? So after the dose, making sure that you're returning to like an okay cognitive function. Some people can get nauseous after the dose. So some people end up needing like ondansetron or something like that after. So just making sure people feel physically well. There's a little bit of a period when after the dose of just like kind of coming back to reality. So just making sure people are like okay before they go home. And then of course they always have to check like blood pressure and make sure your heart and everything is doing okay after. And they're also going to check for like any acute distress. So making sure psychiatrically and cognitively that someone's doing okay and that they don't need to be, stay for longer. They might not need some, like, generally speaking, it's generally okay, but some people could be acutely distressed after, depending on what comes up. So they need to monitor for that as well. Okay. Um, Okay, I'm seeing about pain. So people who receive ketamine for chronic pain is definitely an area that's being studied and used. The doses of ketamine is quite a bit higher for pain because it's actually trying to like disrupt the pain signaling in the body. And usually the infusions are longer and for like many days. So the dosing for pain is actually a little bit unique. So they've received it for a chronic pain condition. It hasn't resulted in objective functional benefit. It gets stopped, but the patient then voices suicidal ideation as a result of no longer having the IV ketamine infusions. I mean, that's a lot for a pharmacist to be managing, you know what I mean, like on your own. But I would say that I'd hope that they'd have a clinic that would be closely watching them. Generally speaking, I haven't seen like clinically the risk of suicide ideation after ketamine, I think is lower. I'd say it's higher for something like MDMA because they sort of get this like huge burst of serotonin and other neurotransmitters, and then they get a crash after, and sometimes that crash after can cause that. But I would just say that without knowing the context of like, is a suicidal ideation just because of stopping the ketamine, or is it because they're feeling distressed that they didn't get the benefit that they were looking for? And I would say that that would have to be explored thoroughly and certainly, referred to, emergency care if, as pharmacists, I think we should always be able to ask about suicidal ideation and do they have a plan and are they at risk in the next 24 hours, right? So really assessing that suicide risk of whether this is something that could just be part of the therapy coming off. And sometimes patients, even just knowing that, have some awareness and that helps them, or is this something different or at higher risk? So that's maybe kind of a general answer to a question that I'm sorry I don't have like all the details of, but I would never just say, oh, that's normal, go home, you'll be okay. I think you still need to treat it as serious. And I'd say the vast majority of patients that I've seen that have tried ketamine haven't had suicidal ideation. So I think it's not impossible, but it's not super common either. But you should always take it seriously. And like I said, things come up. And if they're doing that ketamine therapy and they're not the ketamine treatment and they're not getting the therapy. So this is interesting. Sorry, I don't mean to go on a tangent, but I had an ICU pharmacist tell me once that he noticed that ketamine was being used in the ICU environment I'm trying to remember what they were using it for, whether it was pain or something else, and that he noticed that patients that were given ketamine in the ICU often got really agitated and needed benzodiazepines because of the agitation. And in my mind, I'm like, if you're in an ICU environment going into this like psychedelic dissociative state, like the noises, the sounds, like how distressing that would be, and things could come up, right? Like trauma, like things could be coming up for them and with no way to like integrate it or have the support that they need. So sometimes I also wonder a little bit about that ketamine approach without the therapy and like what could be coming up for patients that maybe we're not realizing needs to be dealt with. So I'd say that there's like a lot of pieces to that puzzle. Have you've seen some compounds as ointment? Interesting. I have not seen ointment or heard of ointment at this point. Oh, I'd say ointment. Like, I think even when we get down to like oral and sublingual, even intranasal ketamine, like all the different compounded forms of ketamine, the variability is very high. And so the effect you're going to get, and then the potential dose that someone has to take, and then the adverse effects associated with that are always like should be at the top of your mind. So I'm sorry, I don't have a lot of information about ointment, but I'd be like really, to me, I'd be really surprised how that would have a lot of benefit. Yeah, maybe for pain. I still feel like the dose of ketamine that you need for pain is high and it's meant to be like infused over like multiple days. I just don't think an ointment could get to that dose in the body. I think to me that's sort of like topical cannabis, topical cannabinoids, which is like very dicey in terms of whether or not it's effective. Yeah. Okay, great questions in the chat. I hope I answered those sufficiently. Let's
There's
jump to
just a couple in the Q&A.
okay. So could ketamine assisted sessions be something ongoing for years or typically just a spurt? Yeah, so Typically a spurt, again, because ketamine is on the market and can be used off label, we're seeing all sorts of things being done. So typically it's kind of those 6 doses. Sometimes it's only 3 doses along with the therapy. Um, Often the way that it's described to patients and the way that I've seen it unfold, this is just from my own like anecdotal experience, um, is that they're kind of told like you're going to get these doses and you're going to potentially see some rapid improvement. But then the way that you interact with the world over the next year is going to change. And that's what patients have kind of said. They're like, I don't know why, but like, I just see things differently. I don't get impacted by things the same way I used to. So even though it's like a short period of dosing, the effects seem to continue longer. And again, I think more so with the psychedelic therapy, but they start to see that benefit. So you don't typically need the years. And I think that like if someone needed to be on it for years, you'd be increasing a lot of those like risks that comes along with like the prolonged ketamine use. The other thing I see sometimes is like the maybe 3 to 6 doses of ketamine, and then some addiction physicians or pain physicians are doing like at home low dose ketamine, like micro doses to kind of like help to carry on the effect. That's totally off label and evidence still coming. Or sometimes people will like do like a top up session every like a couple times a year kind of thing. So I don't generally see the like dose therapy happening for years. Like that would be too much and it's typically not needed. But you might see some element of like top up or doses. And again, I'd say the evidence for all of that is like very unknown right now. You mentioned home sessions. So how would it work if it needs to be administered in a clinical setting and monitored? Yeah, so home sessions are only for ketamine dosage forms that aren't regulated. Like, and it depends on the province. So thinking about Ontario, IM and IV ketamine has to be in a clinic. S-ketamine has to be in a clinic based on how it's approved in Canada. But you could um, intranasal ketamine can be racemic ketamine could be compounded, oral and sublingual could be compounded, and those don't technically fall under any regulations, which means they could be used at home. I think at home dosing is risky, but then also I think health professionals are also trying to balance accessibility. Like not everybody can take that many days off of work or be, you know what I mean? So is there a way for them to also get some sort of ketamine dosing, maybe lower doses that would be lower risk, or maybe they've already done the ketamine therapy and then they feel comfortable be able to take, doses at home. So yeah, it's only for certain doses and it would definitely it's still very cautioned at this point. I don't think it like I wouldn't highly recommend it, but it's definitely being done. And sometimes it's like lower doses that's being done at home. How long should a patient be on oral ketamine? Yeah, great question. The dosing regimen for oral ketamine is actually the same. So typically it's about 6 doses. So even if it's oral, it's still kind of those 6 doses over 2 to 3 weeks. Um, if you're taking kind of the full dose, if you were doing like, again, when you get into the world of like microdoses or lower doses, that might continue on longer, but the evidence is not like great at that point for all of that. Okay. Do I typically see patients off treatment altogether or going back to SSRI traditional treatment for depression and those working better? I've seen a lot of patients come off of antidepressants, but not always right away. Like often they are able to take the ketamine therapy with the current medications that they're on. That's a nice thing about ketamine because some of the other psychedelics like psilocybin and MDMA, you often have to come off all medications because of the risk of like serotonin syndrome, although some studies are showing that you could probably have some level of it together. DMT is, or ayahuasca specifically, not DMT. Ayahuasca is the highest risk where you could like, it's like the full MAO I type of risk with antidepressants. But I've had a lot of patients like stay on antidepressants for like 6 months to a year after treatment and then slowly go off and be like, wow, I'm actually doing it and I'm doing okay. But don't always like go off as soon as they get the treatment or go off before the treatment. And then others, it depends, right? It depends how complex or resistant their condition is. It depends on like the, past trauma. And some people are just really scared to go off antidepressants based on prior experiences. So sometimes like we don't really know if they could, but they don't want to. So I've definitely seen some go off and be okay for a significant period of time off after ketamine. So that's really interesting. And then can at-home dosing be dispensed directly to the patient? Yeah. So, with caution, I'd be asking some questions and all of that, but legally, in terms of how Ontario and Canada regulates it, compounded other dosage forms like oral can technically be dispensed right to the patient. Yeah.
Alrighty, and that does seem like that's all of the questions. So thank you everybody for all of your
Great.
questions. And also thank you, Candace, for such an excellent presentation. Thank you for coming by and sharing all of your experience this evening.
Yeah,
And
thanks.
lastly, I'd like to thank the Ontario Health Center of Excellence for providing funding for this program. And with that, I'd like to sign off and thank everybody and have a great evening. Take care, everyone.
Thanks.
Bye-bye.
Bye.